As a general dentist who has placed nearly 7,000 dental implants, I have come to understand the importance of planning from day one for both the implant placement and soft tissue healing that will best help me achieve the prosthetic goals for my patients. Being able to visualize the finished case prior to ever starting is even more relevant today. With CT diagnosing and treatment planning, we have been able to predictably, virtually place implants using the latest computer software. The use of surgical guides based on the virtual plan has made the procedures predictable and less invasive for our patients. Oftentimes, flapless surgical procedures can be used, which even more minimize the healing time and patient discomfort. With the next generation of the thought process comes the ability not only to determine implant positioning in the bone, but also to determine tissue contouring and immediate loading of our implants with transitional appliances, such as temporary crowns or bridges. Stock components that may or may not be adequate for proper tissue management may no longer be needed. Everything can be customized. Technology allows us to customize each case to determine the ideal tissue contour for each patient. This is completed with custom-milled healing abutments, maximizing ultimate tissue contours, custom-milled transitional or temporary abutments used to support the transitional prosthetic appliance or temporary bridge or crown, and custom-milled impression copings which mimic the tissue contours created by the healing abutment or transitional abutment. This technique allows the tissue to heal properly in the best possible position. The patient and dentist can start to visualize the emergence profile of the transitional restorations. And then the laboratory technician can ultimately understand tissue health, contours, and ideal aesthetics. The use of computer tomographic or CT diagnostic tools can alleviate concerns of impinging on vital anatomy, providing the clinicians with a detailed three-dimensional image of the bone, soft tissue, and other oral structures. This helps us all create an accurate treatment plan and increases our chances for a predictable, surgical, and prosthetic result. When bone is determined to be adequate and appropriate for our surgical procedures, we as dentists can now work with treatment planning software used in conjunction with the three-dimensional models created from the CT scan data to place the implants virtually. Such planning greatly increases the probability of an optimal restorative outcome well before any surgical intervention. So simply placing implants where there's adequate bone may no longer be appropriate. We can now ideally place our implants and understand the prosthetic applications of what we're doing. The sculpting of the soft tissue to conform to the anatomically shaped final abutments and crowns through placement of custom-milled temporary abutments begins as soon as the implant is sufficiently stable, either at the time of placement or after initial healing. It's no longer necessary to wait until the implant is healed to learn whether an aesthetic final result can be created. We as dentists can now feel comfortable in advance that we will get ideal aesthetics. It's my personal experience that if an implant can be torqued into position at the initial osteotomy time to at least 35 Newton centimeters or more, it can be predictably loaded with transitional crowns, as long as excursive contacts are removed and there's no excessive occlusal forces placed on the transitional or temporary restoration. What's nice about CT planning is that the implants and crowns are ideally situated so that forces are maintained along the long axis of the implant. If the implants can't be placed in an ideal position, then more conventional techniques of burying the implant, allowing it to heal or integrate so there's no forces put on it, is probably appropriate. Now, the inclusive tooth replacement solution described in our article does not necessarily require the use of a CT scan. A scan can provide accurate anatomic information that would otherwise be inaccessible, and this would eliminate the risks and simplify our surgery. Most of my patients seem to understand this and are willing to invest in a CT diagnostic procedure. Demonstrating virtual placement of an implant to our patients prior to ever touching that patient seems very logical to them. The scan data and impressions are sent to Glidewell Lab. The models are fabricated and optically scanned. The scan of the model and CT scan of the patient are imported into planning software. Then a web-based teleconference is conducted to finalize our final plan. The surgical guide as well as the 3D model are then printed. Custom healing abutments, temporary abutments, and provisional crowns, as well as matching impression copings, are designed and milled. These materials are a thermoplastic material that are easy to shape and contour in the mouth. In the cases described here today, the CT scan is done with the patient's teeth open at least 5 millimeters. A cotton roll or stack of tongue depressors can be used. You don't want the patient to be scanned in a fully occluded state or clenched, as this could create overlap and inaccuracies of the temporary prosthesis. The laboratory can then provide various surgical guide options. In the cases that follow, surgical guides that are compatible with universal keys from Materialized Dental were utilized. This consists of a single surgical guide for each case. Keys based on the drill diameters to be used are placed in the sleeves in the surgical guide, and this guides the individual drills very precisely into the bone. Based on this virtual plan and the clinical determination that there was adequate attached gingiva, the cases were done following a flapless procedure. So let's look at the two cases demonstrated here. The first case show an edentulous anterior maxillary area. 7 through 10 are missing. The lateral, right and left lateral, and right and left central maxillary incisors are missing. The patients lost these teeth following a very bad fall. She was wearing a flipper-type appliance for over 8 months when she came to the practice. Her quality of life was remarkably diminished, and she requested permanent, fixed restorations. Anterior aesthetics can be a challenge for the best of us. And so what we decided to do was to take a CT scan, and the implants were virtually placed. We were able to determine whether or not there was adequate bone to accept the type of implants that we wanted to place. And we virtually placed the implants because we could determine precise positioning of those implants, making sure that there was adequate bone support for our final prosthesis. It was determined, because of the anatomy of the bone and the shape and contours of the bone, that we would place 2 implants in the lateral incisor areas and eventually fabricate a fixed bridge. Because of her very narrow maxillary arch, it was determined that placing more implants would have created an aesthetic problem for us. So at this point, we're demonstrating the fact that the dental laboratory, Glidewell Lab, created a surgical guide with sleeves to accommodate various keys used for each diameter of drill. Now remember, we virtually placed the implant, so we know the type of implant, the size, shape of implant that we're going to place, as well as the brand that we're going to place. And so this surgical guide will allow us to predictably place the implant in ideal position. This will be a flapless procedure. Figure 4 shows the 2.3 diameter key inserted into the sleeve of the surgical guide, and a 2.3 diameter, the drill is actually 2.0 millimeters, pilot drill is used to create the initial anatomy to the predetermined depth. The predetermined depth was determined by the CT scanning software, where we virtually placed the implant in the correct position. correct depth, and correct angulation for ideal aesthetics. Following this, we simply move to the next size key, which here was a 2.8 diameter. This would be the final drill for this relatively soft bone. A 3.4 dense bone drill was used to create the final width of the osteotomy to accept our 3.7 millimeter diameter dental implant. So you can see these are self-threading implants, and we are undersizing the osteotomy site for our dental implant. So the site that we created is actually slightly smaller than the diameter of the final implant. So this gives us outstanding initial implant stability. We remove that surgical guide and we can see our osteotomy sites in place, and we're going to place our Glidewell implant into the osteotomy site. We're simply hand tightening it to get it started, and then we use an implant driver with a torque wrench for final torquing down or seating of the implant. Note that one of the flats of the internal hex of the implant should face towards the labial. This will give us our best aesthetic final result. And this will eventually match the orientation of the implant analog in the model. So you want the flat side of the internal design of the implant to face towards the labial or facial. Figure 9 shows the immediate placement of the implants in the maxillary right and left lateral incisor areas. Very little bleeding, and the flapless procedure is relatively non-invasive. Anesthesia was obtained by simply infiltrating the soft tissue. Figure 10 indicates the digital radiograph of the implants, ideally positioned as precisely determined by the CT scanning software. And we also took a final CT, which will illustrate also the position of the implant, which exactly mimicked the pre-surgical virtual determination. This is amazing surgery today. This is what is very unique about the inclusive tooth replacement solution. Glidewell Lab provides a custom healing abutment, approximating ideal tissue contours, which again were predetermined using the CT scanning software, transitional custom milled abutments used if the implants are torqued to a minimum of 35 Newton centimeters, which they were here, and custom milled impression copings that will be used after integration and tissue healing. The laboratory also pre-surgically fabricated a biotemp bridge, number 7 through 10, from lateral incisor to lateral incisor. All are the approximate ideal tissue contour and emergence profile that were determined using our computer software. This is the next generation in diagnosing, treatment planning, surgical intervention, and prosthetic reconstruction. The laboratory is giving us the final products for transitional restorations prior to any surgical intervention. We see that at the time of surgery, custom healing abutments are positioned into the implants. At this point, the patient's maxillary flipper appliance could be adjusted, could be relieved, and the implants and soft tissues allowed to heal conventionally, depending on your thought process and how you want to handle the case. You can see there's very little bleeding, nice tissue contour, and the laboratory pre-contoured or prefabricated these transitional healing abutments to allow for some soft tissue contouring immediately following surgery. Because the implants were indeed torqued to 35 Newton centimeters, I decided to go ahead and place our temporary abutments, positioning them into place to accept the provisional bridge from maxillary right to maxillary left lateral incisor. Tissue contours are being established for the first time right following surgical placement of the implant. This is an amazing step towards prosthetic reconstruction. A transitional bridge was seated immediately at implant placement. All excursive contacts were removed. In this case, the patient exhibited a class 2 relationship with no anterior occlusion anyways. And you can see that the laboratory was able to fabricate something that was very decent as a transitional or temporary restoration. And she was absolutely thrilled that she was able to eliminate the flipper that she had been wearing for 8 months that had diminished her quality of life dramatically. You can see right and left smile, and we do have some issues of the maxillary left posterior area. That was an old bridge that isn't very aesthetic. The laboratory did something for me very special that I'll demonstrate in a second. Occlusal view of the bridge in place, and a smile. Immediately following implant placement, we put in temporary abutments, and we loaded a transitional bridge. However, if you did not feel comfortable with that, we could have taken a step back, put the custom milled healing abutments in, and relined her flipper and let her wear that in a more conventional method. If the surgical intervention is not excessively traumatic, a final impression could indeed be made using the custom impression copings provided by the lab. Again, all this was made prior to any surgical intervention. This allowed the laboratory to begin fabrication of the final zirconia abutments and bridge while the patient is healing. This is an optional step that can be saved for therapy following integration and tissue healing, depending on the circumstances. And again, this allows you a lot of leeway as the practitioner. This material is soft enough that if we do decide to take our impressions following integration after 4 or 5 months of healing, we could prepare this abutment, and the laboratory would then have something very ideal to start making the final aesthetic prosthesis. This is totally different than what we've done in the past, where we've had stock impression copings. So we may have nice tissue healing, but then we put a straight impression coping in there. The tissue shrinks, and the laboratory at that point has to guesstimate where the soft tissue is going to be. So when we seat our final bridge, we get blanching and potential tissue trauma. All of this is done prior to any surgical intervention. An impression can be made, and the laboratory can certainly start contemplating what the final prosthesis will be. The impression is made crisp and clean using polysiloxane materials, and the impression copings are then removed and snapped into the impression for the laboratory to fabricate a master cast. Now, the laboratory was kind enough, because we knew we'd have some aesthetic concerns, to determine that the maxillary old bridge needed to be removed. So while they were fabricating the immediately placed bridge number 7 through 10, I asked them to create a temporary bridge number 11 through 14, maxillary left cuspid all the way to the molar area, to be seated at the time of delivery of the maxillary anterior bridge. I knew the aesthetics and function of her existing bridge was compromised. This prepared the patient for implants in the future in teeth number 12 and 13 areas and eventual aesthetic redesign of her maxillary right quadrant. What a motivation we had for this patient to continue her aesthetic reconstruction. And we can see in the following photographs right and left lateral views of the temporary prosthesis placed immediately at the time of surgical intervention. Amazing. Our second case was a person who had a periodontally involved maxillary left central incisor. The tooth had supererupted, was mobile, and was obviously an aesthetic concern for our patient. Figure 2 demonstrates the digital radiograph of the periodontally involved maxillary left central incisor, tooth number 9. Again, a CT scan was done, and an implant was virtually placed in the maxillary left central incisor area. My plan was to extract the tooth and immediately place an implant. Now, this can be a challenge in a periodontally involved area, but that was my original plan. Once virtual placement was determined, a computer-generated model was fabricated. Again, a surgical guide was created to position the implant correctly. We would then do a flapless procedure, placing the implant following extraction of the central incisor. Figure 6 demonstrates the use of the inclusive tooth replacement solution, and a custom milled healing abutment, temporary abutment, and impression coping were fabricated along with the biotemp provisional crown. Now, very important to realize that it's possible in a periodontally involved area, tooth extraction area, that we may not be able to torque that implant appropriately, and we would not necessarily immediately load the area. So a flipper type appliance was also fabricated, which again gives me a little safety device. If I didn't feel the implant was torqued, nor should it be immediately loaded, I could put the custom milled healing abutment in place and then use the flipper type appliance to replace the missing tooth. The tooth was atraumatically extracted using the incredible physics forceps. And those of you who are not familiar with it, I challenge you to Google golden forceps. It's just a wonderful tool. Figure 8 shows the surgical guide that was again created, positioned, and the appropriate keys would be used to guide the drills during the preparation of the osteotomy. Different size keys are used for different diameter burrs. Again, angulation was virtually determined using the CT scanning software. We know the depth that we're going to, we know the position we're going to, and we also know the final width that we're going to go into. The Glidewell implant is carried to the site and positioned and torqued to approximately 35 Newton centimeters, so we did get good torque. It is important to finish seating with one of the internal hex flats to the facial, matching the orientation of the model as closely as possible. It will give you the best final aesthetic result. So the implant is threaded in by hand, and then a ratchet is used with an internal hex torque driver, and the implant is positioned. And you can see that we were using the torque wrench. We were able to torque it down to 35 Newton centimeters, which is wonderful. Now, as I demonstrated before, if we torqued to 35 Newton centimeters, theoretically, we could load that implant immediately. We took a digital radiograph of the implant in position, and you can see that the neck of the implant approximates the cemental enamel junction of the adjacent root. So we should get good emergence profile in our final restoration. Now, even though the implant torqued well for me, I decided, because of the soft tissue, to simply place the custom healing abutment and seat the flipper appliance, allowing integration to progress normally and predictably. We will allow 4 months of healing, and the implant should be in great shape. You can see the flipper is placed, and we got a great aesthetic result. Patient was thrilled, even though they had a removable appliance, because the aesthetics were dramatically improved in our final case. After it heals, we can still use the custom milled transitional or temporary abutment to eventually place that biotemp while the lab is finalizing the final zirconia crowns. And we can also use the custom milled transitional impression copings. Again, we're trying to establish our contours of our tissue, which makes the job of the laboratory technician that much easier. So a striking feature of the inclusive tooth replacement solution is that it allows for substantial treatment versatility while enabling excellent soft tissue contouring regardless of the choices made. If the dentist finds it impossible to torque an implant to at least 25 Newton centimeters, the healing abutment included in the process can be utilized, and the soft tissue around the implant can be trained to an ideal contour. After osseointegration occurs, the healing abutment can be replaced with a custom transitional abutment, which duplicates the tissue contour of the healing abutment that we placed. Because the contours of the transitional abutment mimic those of the patient's original tooth root, the soft tissue healing that occurs around it sets the stage for an optimal emergence profile when the final abutment and restoration are delivered. Alternatively, if the torque is 35 Newton centimeters or more, in my opinion, when the implant is placed, a custom temporary abutment and provisional crown could be placed. Our advances in diagnostic technology and surgical protocols have made dental implant treatment substantially simpler, safer, and faster. The introduction of this inclusive tooth replacement solution takes that simplification even further. It eliminates the biggest barriers to placing implants and provides all the tools necessary to work from the very onset of treatment toward achieving the most aesthetic restoration possible. We have that obligation to provide our patients with the most innovative, proven techniques available.